Hello, and welcome to Reede Scholars Live. I'm your host, Mary Fleming, and the current president of Reede Scholars. Reede Scholars is comprised of physicians, dentists, and mental health specialists committed to collective action to achieve health equity. The purpose of this podcast is to have conversations with leaders in health equity to discuss innovative solutions to narrow the gap in health disparities. With that being said, let's talk health equity. Today's guest and fellow Reede Scholar is Dr. Rhea Boyd. Dr. Boyd trained at Notre Dame in Indiana and at Vanderbilt in Nashville, Tennessee before taking up residency in the Bay Area, where she completed her residency training in pediatrics. Dr. Boyd uses her voice to advocate for vulnerable populations, but also to critique the intersection of racism, health, and justice. She has published in The Lancet, she blogs on her own site, and travels nationwide to speak to audience on how racism is affecting the health of our country. Welcome, Rhea. Thank you so much for joining us today.
Thank you so much for having me. I'm excited to chat.
Any updates? Did I miss anything? Have you done anything exciting that we need to know about in the past, couple weeks or months?
Let's see. I'm working on a couple of new projects, some of which I started during my fellowship year. So one of my learning goals, I graduated from the fellowship 2 years ago, and one of my learning goals then was to better understand the growing data infrastructure in healthcare and how that infrastructure could perpetuate or potentially be used to dismantle or eliminate forms of racism within healthcare. And so more recently, I have been speaking and writing and learning more about that topic. And just a couple of weeks ago, I was in Baltimore with Data Across Sectors in Health, which is an RWJ-sponsored nationwide networking platform that connects public health agencies and health nonprofits and clinics and hospitals who are all interested in sharing data among their local agencies that support population health. And it was really a good experience.
That's exciting. Yes, I actually had a chance to watch your talk, and I'm hoping we touch on that a little bit today. But I also think this topic is so huge. I'm hoping that we'll be able to talk again in the future and get a little bit more into the kind of meat of data and health equity, especially as we come up to the symposium next spring. So definitely want to hear more about that. I wanted to start going back a little bit, and I always like to learn, everybody's past, like how did we get here? And I think it's great for people to understand our guests' personal journey to health equity. So can you tell us a little bit about how did you start down this path? What led you to this particular aspect of health equity, or were you doing something before and you had a shift, or whatever you want to kind of share of your trajectory?
So for me, I would say, even when I was a little girl and I thought a lot about being a pediatrician, I always imagined pediatricians as kind of helpers in the world, as people who keep kids safe and protected. And I thought about that even more than I maybe thought about their clinical role. And so even as then I volunteered in high school I grew up in Akron, Ohio, and we have a children's hospital. And so I would volunteer at that children's hospital when I was in high school to see if it felt like a good fit for me. And even when I was doing my pre-medical prerequisite studies in college, I was always thinking more about what does it mean to kind of be a helper and protect kids. And so I think I came to the ideas around health equity really early in my interest in medicine. But then I always say also to trainees or students who are coming up now, sometimes people will say to me like, oh, it must be your lived experience as a Black woman that helps you know about these topics. Mm-hmm. And I would say, in a sense, that can be true because my parents never shied away from exposing my sister and I to issues of racism that existed in their workplace or in our community and how that affected us personally and more broadly where we lived. But at the same time, I think the Reede Scholars is such a critical platform to demonstrate that, like, it's not just that I'm a Black woman, it's that we as scholars have put so much time into learning more about health equity and learning more about racism and learning more about health policy. And so I would also say I have been privileged and blessed to have an enormous amount of education at this point to support my interest in health equity and some of the work that I've been doing.
I think that's a very important distinction. And I think for those of us who, have the quote unquote lived experience, yes, sometimes we understand the experience, but we don't necessarily understand the implication or how to change or talk about the impacts over time. I'm from Louisville, Kentucky, which is probably not too much different from your hometown. But, I think with, and I feel the same way about the fellowship and learning how to have the conversations and how to translate the information into a usable form when talking to other people. So I would definitely agree with you about that. I think the other thing is, we can talk a long time about racism itself and how it influences health equity. And I definitely, I mentioned it before, with that you have your own blog, and I think it's great for highlighting these nuances in a very usable and conversational way. And I think you do that well. I really enjoy how you articulate the conversation. And I also, you mentioned the Dash All-In conference before, and I think you use that platform to give some very useful definitions for people to understand not just the word racism, but how does that manifest in everyday life. And so I wanted to ask you if you could give us a couple of examples just to set the framework for the rest of the conversation about what's the real difference between our concept of overt racism, what we think racism is and how it looks, day to day in America, versus the more implicit bias forms of racism or the more intrinsic, infrastructural, structural forms of racism and how those manifest.
This is a good question, though, because I think when I teach students and trainees, I always try to make this distinction really clear, because I think the differences between implicit bias and structural racism or institutional racism are really easily and often conflated. So implicit bias, first, I guess I'll say the difference is levels. So implicit bias is something that happens at an interpersonal or individual level. So if you have an implicit bias, it's an unconscious preference or prejudice for one thing, group of people, whatever the thing is, it's a preference for one thing over another. But that happens between one human and another human. Structural racism or institutional racism happens between broader systems that have rules through which groups of people are treated in a certain way or a different way. And those rules then have implications for how entire populations are treated, not just one individual. So an example might be, and I'll just choose a benign example, like an implicit bias might be that I prefer to wear red sweaters. Like, that's a specific thing that I prefer for myself. But if you go into a workplace and they say, we only want to hire people who wear red sweaters, then you're discriminating against anybody who owns a red sweater and might want to wear it to their interview or maybe wears it every day. The example is the level is either one-on-one, and implicit bias tends to talk more about the types of bias or racism that's unconscious, but explicit bias is also one-on-one between one person and another, and institutional bias, where an entire system treats groups in a specific way. And I tend to focus in my work more on institutional or structural bias or racism. And I think different scholars tend to choose one or the other in their focus.
And I think that helps us lead the conversation in a different way. And for many of us, and I think on a day-to-day level, when we can, it's like anything else. It's like, to use a health example, for people who have high blood pressure and they're like, oh, but I feel fine. But no, your blood pressure is 200 over 100, right? You're not fine. And it needs to be treated, right? So sometimes it's so much easier for us to treat things that we can see. Mm-hmm. And so I think when we talk about racism, like, if somebody uses, racist language out loud towards some person, then it's like, well, I understand, I see that. But when it's built into the infrastructure of a system, it's not as easy to see. And so, I've heard a little bit more about talking about racism as I should say we have started talking about racism as a contributing factor to poor health outcomes, right? And I think that's different from even when I was in training, 10 years ago. We talked about health disparities. We talked about socioeconomic factors. We talked about social determinants of health to a degree, but we didn't name racism as a independent factor that contributed to poor health outcomes. And so I feel like that is a shift in the conversation. And I appreciate that shift that, we can't, like anything else, we can't address it if we don't name it. And so I do appreciate that we have been given more and more platforms and spaces to talk about it. And I do feel like we're moving in a positive direction in that way. And using the kind of the analogy of chronic disease, which is what I feel like a few more people in the space are doing, in recognizing that these symptoms can sometimes be ignored or unseen, and also chronic in the degree that we can't just, fix it. We can't just wave a magic wand and say, oh, our country's not racist anymore. We can move on. And so I think changing to that conversation makes things a little different. With that being said, do you see any major strides or accomplishment in the area that say we are moving in the right direction? And vice versa, are there any big hurdles or obstacles, or if we've made any, two-step backs in any areas that, are areas that we need to kind of do more work?
Yeah, I think you kind of outlined one of the areas where I'm not sure if this is progress or if it is stalling us. And that is the focus a number of health organizations have on implicit bias. I think they tend to focus on implicit bias because, to your point, it's easier to recognize. It's easier to own because it's something that happens unconsciously. So you can say, well, that wasn't my intention. And it kind of happens one-on-one. So in that regard, trainings might be a useful way to rid systems of something like implicit bias. But when you want to try to weed out how the rules treat people differently, how policies that structure how people move and navigate through systems shape outcomes on the other end, it's a much more complicated problem, I think, in some ways to face, because you could have individuals in that system who don't have any implicit bias, who are all completely well-intentioned, who hope the best for every patient or client they serve, and yet they have stark racial disparities or inequities in health outcomes. And so then I feel more challenged about what to do about that. Like, is talking about implicit bias a step for us towards talking about institutional racism? Or are people offering, those of us who are interested in getting to institutional racism, are they like offering us implicit bias as a way to distract us from actually talking about institutional racism, and they never intend to go that next step? So I'm not sure. I think it's great that we can talk openly about racism. I can say racism. I can say white supremacy. I talk about these things openly in my teaching and public speaking and in my writing, and it's accepted. Things will be published. I will be invited again to speak. But is it really moving people? I don't know. I don't know. I hope it does. I keep trying.
I mean, that's the hope. I mean, it is. And again, you kind of reflect in, medicine, like anything else, evolves over time. And even the words that we use and the data that's out there. And when I was in medical school, the catchword at the time was cultural competency, right? And, we since learned that wasn't quite, that wasn't really moving us in the direction that we needed to be. Yes, we talked about it some, but, it was very skim the surface. And some of the, I feel like rhetoric is a strong word, but some of the terminology and the teaching in these, day-long sessions that was supposed to fix cultural competency in a day, right, in these institutions, probably reinforce some of the stereotypes, reinforce some of the feelings behind that are influence implicit bias, if you will. So, I clearly don't have an answer, but I think, at this point, all we can do is keep trying, right? And hope that at some point we will get back. We have made some accomplishments. And so, one of, the goals of the podcast is to talk about innovations and where do we see areas of intervention or action, if you will. And I think one of the things you brought up in your DASH talk was not just about addressing health equity in your day job. So, we talk a lot about health equity and health equity spaces or in health spaces. And so I do feel like we spend a lot of time preaching to the choir, right? Like, well, we know these health disparities exist. We know there's data around them. And, there are some initiatives or programs or projects, if you will, or we need more data around these topics, but not actually putting any action to change people's minds or their actual everyday actions. And so one of the things you said is let's move it outside of your day job. So if you're talking to your colleagues or your in your neighborhood meetings or your PTA meetings or school board meetings, because health equity is not just about the healthcare space, right? It's about the transportation space and the education space and access to resources in your everyday life. So are there any other thoughts? Would you like to expound on that anymore? Or are there any other ideas that you have we can be more innovative or creative in having the conversations outside of the academic space, if you will?
Yeah, I think one of my colleagues that I met on Twitter, Dr. Ariana Planny, tweeted out maybe a couple of months ago something that was so provocative. And I don't even know if this is a direct quote from her, but I'll attribute it to her because it's where I first heard it. She said, healthcare is insufficient for health equity. It's necessary, but it's insufficient. And what she's getting at is like, if we only think of our role in advancing health equity in terms of how we do that in a clinical environment, we'll never get there. Because we know that everything that exists outside our clinical environments contribute to people's health, wellness, or, disease and demise. So what I was trying to say at the end of that talk was getting people to think more about how they just show up in the world in general. Because if part of what makes health inequitable is that we have profound inequality in society, we have some people who have a lot and way more people who have not enough. And doctors tend to be in that group of people who have a lot. And even if you didn't have a lot when you were a kid, becoming a doctor puts you in that group where you can start to have a lot. And that means you have more choices when you go back out into the world about where you choose to buy housing, where you choose to send your kids to school, what businesses you support, how you vote, what type of politics you engage in. And those are places where I think people who work in healthcare have to think about being more responsible. Like, if you really care about health equity, do you support your local public schools, or do you send your kids to a private school in a failing, district? These are deeply personal questions, but I think it gets to the root of what it would really take to push forward change, to really move the needle. We can't just talk about it at work. We can't just pretend we're going to do one thing, but live our whole lives in a way that's the antithesis of that thing. We have to be like that all the time and challenge each other and hold each other accountable for being like that all the time. And that's really hard. I mean, there is data that doctors aren't even, of professions, we're not even a profession that votes the most of everybody, but voting is a way that really shifts local politics. And that's a way that really informs health equity and resource dissemination across communities. Like a very simple way to show up in the world in a way that supports health equity is to vote for health equity. But not everybody does. So I feel like, to your point, it would be a great place for people to start, is not just in your workplace, but more importantly, in your home and your neighborhood.
And, we have so many historical examples of the shift of resources, right? And, we talk about, the 1950s and 60s when the shift in demographics in the urban settings and the suburban setting developed, and how those shift of resources changed our education system, right? And so I think that reinforces your point. That shift is still happening, but it's just a little bit less visible, right? Because our neighborhoods are a little bit more established, and, we have charter schools and we have public schools and we have, private, faith-based schools. And this slow shift from out of the public schools into these other schools, and how that is depleting our resources in the inner city schools, and not just inner city schools, some of the rural schools as well. And it's just kind of one of our examples. And that's where, all of these things begin in childhood. And one of the reasons I always like to start with, how do things begin, is because these are when all of these, how we interact with people starts at such a young age. And so the things that we see and the things we're exposed to at that age is going to influence how we mature and grow. And so if we don't put that emphasis on early education and making sure that it's a place where at least our kids can be educated in an equitable way. So it's not unbelievable that when we grow up that we're still participating in a health system that's inequitable. And of course, there's plenty of other examples, that we could use to kind of show that dichotomy. But I thought that was a great, way to illustrate it outside of the healthcare space. Because I feel like we spend a lot of time talking to each other, but there's a lot of other opportunities for us to hold the conversation. So kind of shifting gears a little bit, I am very hopeful that I can have you back on in the spring, because I would like to talk a little bit more about how, as we move into this increasingly technological space in and outside of healthcare, and the increasing amount of data. I think in your talk, you talked about exabytes or some word I'd never heard about. I was like, geez, Louise.
Oh, yeah.
And so, we're collecting more and more information from more and more resources, and, not in data in that, research data, but just data that we're getting from all of these other technological spaces. And like, what do we do with all of this information, and what is our responsibility as, citizens? What is our responsibilities as physicians? What is our responsibility as whoever owns this data, which I think is still truly addressed. So I definitely want to, come back and talk about that as we get ready for next year's symposium. But anything that you kind of want to leave us with today, or, do you want to challenge us to think about in that space, as we get ready to close out our conversation?
Sure. First, thank you again for having me, and I would love to come back in the spring. The other issue that I have been writing about and thinking much more about, that I started to touch on in that DASH talk, was about whiteness and health. Because there's evidence to show that although we tend to think of white people as faring better in the U.S. healthcare system, and by many accounts that is still true, there's evidence to show that white middle-aged Americans aged 45 to 54, their mortality rate is increasing. And for younger white Americans, the mortality rate associated with the opioid epidemic is increasing. And then if you look across the major causes of death, heart disease, cancer, the mortality rate for white people is increasing as well, which raises questions about how we used to talk about health disparities. Some of those questions are, we used to define like the gap between populations who had the worst health and populations who had the best health by comparing populations to white populations who were considered to have the best health. But now, if at a population level, white health is declining, we now have to ask kind of what is kind of the litmus we're going to use to determine where we're trying to bring everybody's health. And then the second question that I'm really fascinated with is kind of what's happening to white people? And is it in any way similar to what's happening to Black people and the indigenous and certain groups of immigrants and non-white people in general in America? How does structural racism and whiteness in particular affect population health for everyone in the United States? And before we saw this striking trend in mortality rates for white Americans, we didn't really have the same impetus to have that type of question. I think we used to say things like racism hurts everyone, but it wasn't always apparent or evident how it hurt white people. And now to see that in the United States, amidst our growing economic inequality, like that white people are also faring worse, I think it's challenging us to think more about how racism works for everybody who are racialized in this system, which white people are also a racialized group of people. So if I left folks with anything, it would be to take up some of these questions. How do you define the gaps in health, and what should our standard of health be? What population should help us set that standard? Should it be an international population now? Or how should we set it? And then what do you make of what's happening to white people and what that means for all the other populations who have suffered poor health in this nation since its founding? Is it a commentary on racism? Is it a commentary specifically on whiteness as a type of racism? And how do we address it? So I'm still thinking of the answers, and maybe next time we talk, we could take up that question too.
Yes, that is. I'm trying to think of even how to respond. That is so much, right? Because that's a total paradigm shift when we think. I mean, and I agree. Like we always usually say, if it's the same thing, right? The weakest link concept, right? If we're not treating the most vulnerable population or vulnerable of our population well, then everybody is going to suffer. And so, you extrapolate that to racism. If you're actively oppressing a group, at some point the whole is going to suffer. Mm-hmm. But when the majority group is manifesting signs of that suffering, that shifts how we have the conversation. So that is very interesting, and I am definitely going to stay tuned to learn and talk about that some more. But thank you again so much. I really appreciate you coming on today, and I would like to encourage our listeners to be on the lookout for Dr. Rhea Boyd. I think we're going to see very, very exciting things coming from her in the future, and she is such a dynamic speaker. So if you do get a chance to see her in person or watch one of her videos online, please do follow her blog. And I think it will help as we move this conversation forward, and just, learning new vocabulary words and learning new concepts. And I think it's going to be a quickly evolving conversation. And I hope everybody is willing to get on board. With that being said, thank you again. I hope you have a good day, and we look forward to talking to you again soon.
Thank you so much. Ditto.
Thank you for listening to Reede Scholars Live. Please follow us on Facebook, Twitter, or Instagram, or subscribe to our YouTube channel.